issue, but some people feel that despite the fact there's a medical issue, maybe at a point there are some spiritual ramifications to it. We have to draw the line between when it still remains a medical issue and when it crosses to the realm of spirituality is a difficult one. I think that's the area for professionals to look at and also advise us. But I think it's between the two. Maybe some of it may be purely medical, some of it may be somewhat spiritual. That's what I feel.
Thank you, sir, for the feedback. Okay.
Any other question? I'm raising my hands.
Yes, sir. Yes,
hello.
Ma. Please go ahead, Ma.
My name is Adigat Tijani. I think depression is actually when the body and the mind, when they are not in sync. And then it can be seen as a psychological issue, a medical issue, as well as a spiritual. So the three is actually what can be tapped into to be able to address it appropriately. That's just my own opinion about it.
Okay. Thank you very much for the responses. So I can gather that we all have, I think almost similar reasons to what we think depression is. We think it's a medical illness. We think it's, it could be psychological, it could be spiritual. Okay, so let's go deep into the lecture. The objectives, or what I intend that by the end of the lecture, we will get to know is, I'll give a brief introduction, which we started already. I'll give a myths into what people think about what depression is, the general myths they have to the term itself, depression. Then the burden, how much is it? How much do we find it in our environment? Then the symptoms of depression, the core symptoms, how it really manifests. Then I'll talk about the forms, the variants of depression. We have it in different types. Then the causes, the possible causes, we try to put them down into points because there are actually various causes of it. Then the complications of it, and then I'll give us a brief management of how we can tackle it. Okay, so when we talk about depression, when we, the way we take it, depression is an English word. It just means for somebody to be sad, for somebody to be unhappy. But when we are looking at it from the psychological perspective, from that depression that we call a medical disorder, we term it to be an overwhelming feeling of sadness. Not is a feeling, the person feels it. It's not something that is imposed or something that you imagine. It's something that you can see it in that person, that it is overwhelming sadness that interferes with how one thinks, with your daily life, with your daily, what you do, your daily day-to-day activities, the way one thinks. So imagine one having that overwhelming feeling of sadness that interferes with how you run your daily life, with how you think, and with how it just disturbs your functioning. So that overwhelming, the overwhelming sadness is not something that is pervasive. That means it's almost all the time like that. It's persistent. It's not as if this minute you feel it, the other next 2 hours, it won't be there again. You will overcome it. It will shadow. It will cover all your mood. Everybody will know that there's something sinister about this person. It is also contains of there will be different symptoms, which I will mention later. And then, as I said, the pervasiveness, the persistence of this overwhelming feeling of sadness, when it has been persistent like that for 2 weeks, the duration for 2 weeks that is affecting one's functioning, then you say that that person is having a depressive disorder. Then, so let me quickly go into the myths. So people usually say that, oh, one cannot have depression. Depression is all in your head, that one is forming it, that, you know, it's something that, yes, now one can feel sad. You just have to suck it out. You just have to suck it up. There's nothing that's one that they don't actually have that meaning of what to think that somebody can actually have that feeling of that sadness for that long. So they say it is all in your head. Shake it out, put it out. No, it's not like that. The person is ill and needs attention. People also say that, oh, it is brought by a traumatic event, that, you know, maybe somebody died, something happened, there is a loss. That's why people have depression. No, it is not so, usually. Yes, we could say that that could be a trigger to it, but that person is vulnerable, is prone to having depression before that probably, you know, sad events come along. So it is not that it is the loss or the sad events that makes the person to have it. That one just pushed it out. Then we also say that dealing with depression is a normal thing. Depression, as I'm trying to explain, is an illness. Illness is not normal. Yes, sadness is something that is part of life, but we've already tried to differentiate between depression and sadness. That depression is overwhelming, persistent, pervasive, affects one's functioning over like 2 weeks or more. Okay. Then people also say that people experiences depression in the same way. No, there are different manifestations because of, you know, one's premorbid way of dealing with things. Some people people might not really know that they are going through a lot, but when they see the professionals, or when they will know that, okay, there's something actually wrong. So the way people manifest depression can be slightly different from one or the other. The way females manifest depression can be a little bit different from how males manifest their own symptoms of depression. Then another common myth is that it's only women that get depressed. That big men are always, you know, big, they always know that they don't get depressed. This is very wrong. Yes, women seek for help for these things more than men, but the ratio of how they have these manifestations of depression is almost the same. Then that people also say that depression is a sign of weakness. That, oh, it's because that person is weak. That person cannot, you know, deal with the life issues. That's why the person is having depression. That no, only that no, it's not. It doesn't. The illness doesn't cut across gender. It doesn't cut across how influential you are, how rich you are. It's an illness and it can occur in anybody, no matter who you are. So it's not a sign of weakness, or so it can be affected. Anybody can be affected. So moving further now to the burden. Depression is the leading cause, if not the most common cause of disability. Disability, I mean that, you know, that you not be able to do the things you want to do out of the non-communicable diseases. That is, you know, that the thing they want to, it just renders one like almost, you know, almost useless, kind of. It makes your productivity to be low, and also depression is one of the leading cause of that. And it's so common among us, but it's not that people don't usually identify it, or they just term it to something else and all that. You know, it's when people go to GOPD, that's the subtle signs of depression is what they go to complain about. But because it's not identified, they keep giving them, you know, all sorts of pain relieving drugs, and all that. So it's a common cause of non-communicable, leading cause of disability among the non-communicable diseases. It's also the second leading cause of death in the middle age, between 15 to 29-year-old, because these people, they are in that productive, youthful age group. They don't want to accept that this thing is happening to them. So once they don't understand themselves, and that, they just result into suicide. Then coming down to Nigeria, it is reported that 3 in every 10 Nigerians have depressive symptoms, according to our national statistics. And then it cuts across all ages. We have it I've managed a 10, 11-year-old having these symptoms before. It cuts across all ages. It's also so prominent in the elderly, so it cuts across all ages. But the peak, the ages that you usually see them, or maybe the time they usually come to the hospital for you to do something about their symptoms, is between 18 and 24 and 45 and 65 years of age. As I said, it cuts across all races, all ages, and then, but usually we report it less in Africa. We find it stigmatizing, so we don't talk about it. Then depression is the most common cause of suicide. All these people that are jumping over, they are doing depression, something is going on. It's even occurring among Muslims. You find that this person is practicing. How come this person goes on to even think of suicide? Because at that point in time, they're not even thinking. The symptoms, that overwhelming sadness, that overwhelming that they think that everything is bleak, has overpowered them. So the next thing that they want to consider is suicide. So depression is the most common cause of suicide. So this is to tell us how serious and how common this depression and depressive symptoms are. So going to the symptoms briefly. So I will divide them into the core symptoms, into cognitive symptoms, which is more like, okay, how the brain interprets it or how the brain manifests it, and then the physical symptoms or biological symptoms. So into the core symptoms, the person is persistently having a low mood. Everything around the person is doomed, bleak, pessimistic, persistent like that. Then there is no interest in previously pleasurable activities. The person likes to watch ball. The person likes to hang out. The person likes to go for a salatu. No interest, nothing. You just be finding one excuse or the other, nothing. So the person finds no joy in common simple things. Then there's also reduced energy, no power to do the major things. I'm weak, I'm tired. You'll be like, what is wrong? Okay, use blood tonic. You find out that there's nothing. The things that will be able to explain why the person is tired, you won't get it, you won't find it. So once these three core symptoms are there, you want to tag the person as having depression. So other symptoms, as I said, cognitive symptoms, the person will not be able to concentrate. If he's a student, he or she can read so many lines, many times without assimilating. Newspaper, nothing would enter. You will not be able to bring out anything, not be able to concentrate. Person will not be able to pay attention to details. He's always distracted, always engrossed in thinking negative things, thinking things that are not there. Then the person would have a reduced self-esteem. Person will find him or herself unworthy. Person will find him or herself that, okay, I don't amount to anything. I am just, person will feel useless, no self-confidence, cannot talk to anybody. If the person is a CEO of a person, he will be timid, he cannot address, he'll just be like in the shadow of him or herself. Then there's this this person, the person find himself unworthy. For females, they find themselves unworthy. So any man, they can allow any man to do anything for them because of how unworthy or shameless they found themselves to be. They feel that nothing, I don't want anything. My body can be used anyhow. They are hopeless. They are the present, the future, no plans. Everything is bleak. Everything is dark. They are constantly living in darkness. So this, that's why they say that's why they think that okay, the next thing to do is just to end it all. When you know that okay, in the next there's nothing. Why am I still here? Everything is bleak, hopeless. Then this persistent views of they don't have they are not able to, they don't pay attention, so they are not able to remember, they forget things easily. They are not paying attention, so they cannot even make decisions like a mother would think, okay, we'll do this, no, is lost. So the person will be wondering, what is wrong with me? The person will not be able to hold himself together. Imagine having this series of things happening at the same time. Then the contemplation of suicide, ending it all. Those are part of the cognitive or psychological symptoms. Then the physical symptoms, which is what we usually complain as Africans, is that we don't enjoy our sleep. Is it that for the older generation, they usually will not have enough sleep. They will not be sleeping well. They will be on the bed, but they will not be sleeping. They will just keep tossing here and there. They will be the ones to know when 9, 10, 11, 12, they know all the clock, the hours till the morning. And in the morning, they will now feel so tired. They will feel so gloomy in the early mornings. Then, but for the younger people, they can sleep too much. You just be wondering that this person that is supposed to be in school, why is he sleeping too much? Why is he sleeping all the day, sleeping all through the night too? So that's it. Then for some, they won't have appetites. They will not be eating. They will be losing weight. They will not just have they will not just want to eat. Sometimes they will say that they are fasting. Sometimes they will just turn into different things, but you just wonder why is this person not eating? Then for the other side, they could be eating too much. They could be binge eating everything, just be wondering, why is this person eating like this? Then they could be losing or gaining weight in a rather awkward manner. That won't be like, why has this person gained this so much weight in this so much time? What's happening? Or they will have lost in that so much time. Then they will be having, for the females, they will be having menstrual irregularities, the constipation, then unexplained physical symptoms, which I said that we usually complain in our environment: headache, body pain, crawling sensation, heat sensation, peppery sensation, all kinds of, pain problems that you're wondering that where is this one coming from? And as I said, it will be persistent. It will be, and once they don't get that proper treatment, they'll keep complaining, they'll keep going from one place to the other and looking for how to get better. Then, okay, thank God this is on. We are on slide 13 now. Can it be moved there, please? Yes. After this one. Variance, yes, thank you. So the slide before this courses, please. Yes, thank you. Okay, so based on so we are talking about the forms of depression. So based on the number of symptoms and the severity, we can say that somebody has mild depression, somebody has moderate depression, or somebody has severe depressive disorder. So we can term it like that. We can say that somebody has depression with psychosis, when the person begins to experience hallucinations, stimulus that are not there, hearing voices, people are touching, seeing things that are not there. So it's now transcending into another thing. That's what we call a psychotic depression. Or it could be a depression in where the person, we call it a bipolar affective disorder, where that at a point they keep switching poles. At a point they are very depressed as of the symptoms of depression that I've explained, and on the other hand of the pole, they are very active, very very all up and down, or they could be very angry, very irritable. You just feel like, why is this person always bouncing and all that? So we call that type of disorder a bipolar affective disorder, where there are swinging poles between depression and hyperactivity. Then there's also another type of depression that we call dysthymia, when this person will have all the symptoms that I've mentioned, but it won't be to that degree. The sadness, it will not be to that degree that will affect that social occupational functioning that much, but the person will still be there, not get himself. So we call that dysthymia. Have that like sub-threshold symptoms of depression. Then there's another one that we call premenstrual dysphoric disorder. Around the menstruation, around the time of the monthly cycle, this usually occurs in females. Because of the imbalance between the hormones surrounding that are being around the monthly cycle. So the surge and all that. So it makes them to have symptoms of depression again. They get irritable. They have all these symptoms again. But it's only around that time. Once that thing is gone, about 3-7 days or so after, they are back to their normal lives. But it affects them all the time when they're having their menses. Then the seasonal affective disorder. This one usually happens in the temperate region, where they usually have the symptoms of these depressive symptoms at the cold times, winter times, very cold times. That's when they experience these depressive symptoms. Next slide, please. Okay. So then the causes of depression is numerous, is wide, is multifactorial. You cannot pinpoint that this is it. Usually they play together. So when we are assessing, so that we can say probably this. That's why you have to form like you have to like look for what could be the causes in this person. Why is this person presenting like this at this particular point in time? The causes are wide, many, but biologically, or what are the things that we can explain from science that could be causing it? Genetics. It runs in families. Some families have some genes that they pass from one to the other, and that can make them to be prone to having this disorder, especially if it is a first degree. If both parents or one of the parents are having it, they're likely to pass it down to the offsprings. So then if there are imbalances in the neurotransmitters, just how the genetic body makeup is made up, for some people is varied. So this too could also lead to why some people are prone to depression. So then hormone surge, all these things could also affect why some people are likely to have depression. The physical illnesses, especially the chronic ones, just mention any type: sickle cell, diabetes, anything that that you keep nursing for a long time. It's also makes one to be vulnerable to coming down with depressive symptoms. Okay, next slide. Then the psychological symptoms, when there are persistent negative thought patterns, when you keep thinking, when all what concerns you, when all you see around, when all you hear is bad news, when you know that's what we are always exposed to, we are always seeing. You know, there are some people in Gaza, people in all those places, all those war-prone areas, they are always prone to seeing all those things. They're always prone to, they always see it. It's always in their face all the time. So such children, they are perpetually, let me say it like that, prone to coming down with depressive symptoms. And then, you know, when somebody is being modeled, kind of brought up in an hostile environment or in a place where there's no love, there's no touch, that person doesn't have a good self-esteem, is not able to talk. So in those kind of families, raising children in those kind of, they are prone to having a low self-esteem. And so if one is having that low self-esteem, one can come down with depression. Then having poor maladaptive coping skills. If there are, yes, problems are bound to arise. We would have problems. But the way one is, and we learn how to adjust, how to react to these problems, to these life issues that we face every day. So the way one is admired or adjusted to coping with these life stresses also matters, also help, or makes one to be prone to having depression. Like, for instance, if when there's a problem, you escalate it more, you think it's more than it's supposed to be. You don't have people that will make it like, oh, it happens like that. People that will, so it's escalate, and the way you now think it through or think it through can cause one to have depression. Then, if one has been exposed to a lot of trauma and stressful life events while growing up, people that they say that they have all this traumatic childhood, traumatic, all these things, from the very young age, they are also prone to coming down with depression. That's like the psychological causes or reasons we think why somebody can have depression. Then, you know, there are also some personality traits. Personality is what makes you, or how you have been nurtured to behave when you're an adult. So some are, they call them perfectionists. Everything has to be prima, proper. Everything has to be, they are very, meticulous and all that. So if anything goes wrong or doesn't go their way or doesn't, it could also lead them into having or coming down with depression because of their lifestyle. Or if one is too quiet, too introverted, everything is being synced in, everything, no form of releasing any emotion. That's good. That too can make somebody to be prone to coming down with depression. Then let's go to the complications. The complication, these are some of the symptoms. These are some of the causes. As I said, there are no, but let's just find a way to just pinpoint them. So let's go to complications of depression, of having depressive symptoms or having depressive disorder. I think we are majoring on the disorder, the problem itself now. So the most common cause, the most fearful one, is suicide. As I said, depression is the most common cause of suicide, because as I said, everything is bleak, no future, nothing. So the next thing, what they are thinking of is how to end it all. And because this thinking that is going through them, this is overwhelming, it's always occurring. So they don't have any other way about it. So the next thing is that they just want to kill themselves. So if you don't take notes, most likely somebody with severe depressive symptoms will end it all or has tried to end it. It's not all suicide that most suicides are reported, but those ones that have tried to do that one to end it all, the deliberate self-harm, the ones that cut their harms, the ones that have tried it in one way or the other, that have used overdoses of drugs. There are many, much more than the people that actually committed suicide. So they have all these suicidal tendencies. That's one of the most common complication of suicide. And that's why we should take note, because it's not, the suicide doesn't only affect, it affects more of the people that the person left behind. It's as if after the event has happened, they become an outcast. They become like, how do they allow this to happen? What is happening? So it affects their whole way of relating to others. As that, I mean that suicide victims, families of the victims of suicide. Then depression leads to strained relationships. You are not able to, your friend, the person doesn't understand, why are you behaving this way? Why this sudden change? You will not be able to explain what is happening. They, your friends, will not be able to understand what is happening. So it leads to strained relationships. It leads to conflict here and there, conflict at work, conflict. They won't understand you. They'll just feel like maybe you are being lazy. You are being, So, that's, the strained relationships can also lead to couples, marriages breaking down, relationship between parents and their children breaking down. They don't understand why mommy is like this. So for if a young mother is having that, this is also a common time where they have it. Sorry, I forgot to mention another form or variant of depression is what we call postpartum depression. That one is also very common. That's immediately after childbirth. They also experience what we call this postpartum blues. But some can actually go further into a postpartum depressive disorder. So imagine somebody who just gave birth, or who just will not be able to connect with the child. No form of breast milk, no form of, everybody will just be looking at what's happening with this mother. They won't understand. So, I'm just trying to say that imagine the kind of broken relationships, interconflict between a lot of different people that they will not understand why the behavior is like that. And they'll say that, but why is, we don't understand this illness. They don't understand it. But that's depression for you. Then there's reduced productivity at work. There's, the person in business, they'll not be able to, they'll keep losing money. They are not able to make the right decisions. So, there will be leakages. So businesses, jobs, and all that would be lost as a result of somebody coming and having depression that is not well managed. Then another common thing is that because they are trying to cope, they are trying to find solutions, they engage in psychoactive substances, especially alcohol. They think that, okay, maybe when they take alcohol, when they take this, it will numb the effect of how they are feeling. It will make them better. They will be able to, they will be able to have, they will be able to have energy. They'll be able, so they engage in all different types of psychoactive, so all different types. There are many different types of psychoactive substances nowadays that people engage in. All these bitter cola, all these kidney corn, Swedish bitter, all these, there are so many types that, but the constituents of what they use to make these things is the substances that are there that might not be really good. Then fear of being judged. So they just keep quiet. They don't talk to people. They feel stigmatized. That's okay. I have depression. Who would I tell? They will say I'm weak now. That's why I'm having depression. So let me just keep it to myself, and then it lingers on like that. Then the management of depression. Usually we say that because depression can also mimic other forms of mental disorders. There are several types of mental disorders. One of it is this depression. We have, schizophrenia. We have different types of other forms of psychotic disorders. There are different types of psychiatric conditions or mental health conditions. Depression is one of them. So usually, they can mimic each other such that, they feel that, so they don't understand the person. They feel that the person is being possessed by a jinn, by that, and so they look for different ways to, to send the jinn out or to send the jinn out. So what I'm trying to say is that if there is a sudden change in one's behavior, the person has not been like that, but one notices that in recent time this has changed about this person's, the way the person thinks, the way the person does his things, the way the person relates with others. One should go to, where to go to an avenue where they can be properly assessed and properly assessed based on the type of mental disorder this person is having. If we are sure that, okay, maybe we have heard it before, that it's depression, the person also has to be sure to know the degree of the depressive disorder. As I said, we have them in different degrees, we have them in different forms. So the person must be sure of the type. So that proper assessment has to be on point. Where we can assess that, I would say that it's best to assess it in the hospitals. And then, because there are so many things online, everybody is a mental coach, a mental that. But there's a difference between when you talk to somebody about, promoting mental health, and versus when the person is actually down with a mental problem. So the need for that proper assessment is essential. Then the biological management of depression, usually we give antidepressants. We individualize the patient. Some patients will give them, the types of antidepressants also is many. So we give it based on the peculiarity of each patient. The antidepressants that are available, there are many types, as I said. Then we can also add some other medications to it, depending on the type. We can add antipsychotics. We can add, other muscle relaxants, other types of drugs that we think the person needs at that particular time. Then there are some others. If the person is if the depressive symptom is so severe, we can also give them what we call PCT. That's also a biological form of treatment. Then for psychological, that's where we give different types of psychotherapies, of talking therapies, depending on the nature. But the one that is most common is cognitive behavioral therapy. But in some, it can be family therapy, couple therapy, depending on what is the trigger of that depressive symptom or depressive disorder is at that time. That's what will determine the type of psychological treatment that we want to give. Then we will also want to the social environment, as much as possible. We want to make it as adaptable for that person as possible. Especially this could be maybe for the elderly, that everything around them is down, they are not active again and all that. So we want to stimulate their social life as much as possible. We want to encourage them to do this, encourage them to do that, because most of that, at that age, they would have forgotten, how things are. Depression in the elderly too is something that is common, very common, and usually most of them just overdose themselves. So we also need to take care and take note of that population. Then spiritual. So spiritual is also something that is, very essential. We need to pray for our patients. We need to, ask Allah to heal them and all that. We need to encourage them to also do the things that, their creator wants, and, encourage them to pray, encourage them to do all those things that, it would make their hearts move closer to Allah. So by and large, usually we combine these treatments. We combine the biological with psychological, with social and spiritual, depending on what we see that are the triggers of the depressive symptoms at that particular point in time, and on the severity and how the severity and the forms. So all this would make us to know how to manage. But usually we combine all the 4 aspects of management together at all times. So in conclusion, I've tried to explain to us that that depression is actually it's an illness. It's an illness that we all need to take cognizance of within ourselves, people that we work with, people in our family. We should tend to be able to notice some signs that, when we are worried, we shouldn't keep quiet that, oh, it's just of the season. As I said, the thing will be persistent, pervasive, something that, it will be like that for 2 weeks, like that. So if one notices, one should call the attention. In young people, once their own might be a little, the way their own depressions, the way their depressive symptoms can be a little bit colored, agitative, as if they're angry and all that. So once we just notice there's something about this person that has changed within some few days that is persistent, let's call the people that would, that would help us in that regard. Then I'll welcome reflections, questions, and Jazakallah Khairan for the opportunity to talk in this gathering. And I thank you for your attention. I pray that Allah forgive me where I have heard. I pray that you understand more than the way I have said it. Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakumullah khairan. Amen.
Wa alaikum salam wa rahmatullahi wa barakatuh.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi.
And we didn't read the brief on the facilitator because we have shared it to everybody before now. Is there anybody that did not receive it so that we can go through the brief before we go to question and answer? Then I will allow Sheikh to handle the question and answer section by allowing people to raise up their hand, or they put it on the chat box for us to read it out. Thank you very much. Questions, please. Sister Rafiat, please go ahead.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Lawal, Jazakumullah khairan for this insightful lecture. We thank and appreciate you. May the Almighty Allah continue to increase you in knowledge. Amen. My question is, at what stage do we as Muslims discard the affliction of jinn and take it to be depression of mental ill health? Are there specific things that we should consider? Because as Muslims, we know there are jinns, and we also know there are bad jinns, and they afflict people in different ways. So are there indices that will let us know that this is jinn and this is the psychiatric issue, so that we know how to deal with it? We know when it's jinn, we do ruqya and all that. Is it something that should also be considered for depression? Or how are we going to be able to determine this is depression and this is affliction of bad genes? Assalamu alaikum.
Right, so I got to like, should I answer now, or I should gather all the questions together? Okay, to that. Okay, so to that, it's actually still a puzzling question for me, because now I just see that it's as if that everything, even I don't know, everything now just seems that, oh, it is gene, it is people are just possessed with genes. I don't know. What I'm trying to say is that is it the awareness or the thinking now that people are possessed with genes is now more than what we used to know before. So even before they get to you as a medical professional, they will have done ruqya. They will have done all those things before they start saying, no, it's those people that they will convince them that this is not a ruqya issue, that they should go to the hospital. So I don't know, speaking from a professional level and also a Muslim and all, I don't know. I just believe that we are, especially for the conscious Muslims, we do the things that are needful to protect against genes and all that. We don't walk around. I don't know. That, as I said, I don't know. May God forgive, but I don't feel that that the possession, this thing that people now say about genes is more, especially for young adults. Everybody just say it's gene. So, sorry, what I'm trying to say is that once you notice an abnormal behavior, a sudden change in behavior, best to seek help from a medical professional. Let them tell you what they think it is. Let them convince you what they think it is. Then, if you are, of course, other things, praying to God, doing all those things can also go pari passu. So as I said, the management is bio, psycho, social, and spiritual. Everything goes hand in hand. But it's not as if until we subject the ill patient or the person until we subject them to all these ruqya things and all that before, I think that everything should go pari passu. So that's like what I'm trying to say in a nutshell. Bring the person, when you notice that there's an abnormal or something, bring the person to a mental health professional. Let them assess. While they are assessing, of course, anybody that is healed, we pray for the person. Let us all be doing that too simultaneously. That's my take on that. Allahu Alam. Allahu Alam.
Jazakallah khairan.
Thank you. Well, Kamal Shitu.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi.
Can you hear me?
Yes, we can hear you clearly.
Okay, Jazakallah khairan, sister. May Allah reward you abundantly. My question is, I want you to please explain to us the relationship between depression and anxiety. Then, how do we help an individual that is aggressive, that there is excessive anger? So then, to me, this individual has a lot of energy, and we always look for a slightest opportunity to deplete that energy. So then how can we help such a person? Thank you, ma'am.
Yes, sir. So if this behavior has been persistent, like that, and when the behavior occurs, the agitation, the anger, when it occurs, it's usually socially disturbing, such that everybody knows that there's something wrong with this person. Then please let's take the person for a proper assessment in a hospital. That's what I think. Then the difference between depression and anxiety. Depression is all the things I've tried to explain earlier. Then anxiety is another form of mental disorder, that the person is always perpetually worried about everything. Fear, worry is the one that is that overwhelms the person, such that this fear and worry affects his social and occupational function. So we say the person has an anxiety disorder. So I'm not sure. Did I answer your question?
Yes, ma'am. Thank you. Thank you.
Akindele.
Hello. Assalamu alaikum, ma'am.
Go ahead. You have the platform.
Assalamu alaikum, doctor.
Yes, sir.
Yeah. Thanks for the very wonderful lecture. And while your lecture was going on, you briefly spoke about the influence of the social media, especially how to differentiate from all these form of people that post materials on the media. And if you see that the most disturbing part of it is the area of rendering emergency assistance to people that are on the verge of committing suicide. For example, if you are going ahead, somebody start behaving strangely, and you need to help before the guy jumps into the river or something. From a professional point of view, how do you know that, okay, this person is about crossing the border? And if you're able to determine that practically, what type of assistance do you render to those people before they do the unimaginable? That's my own question.
Okay, so if I could put it in a clearer perspective for me, I'll say that you are trying to ask that how would you know that somebody wants to commit suicide? How would you know? So for people that they are close to one, you can predict or likely think that they want to do it because they might be saying things like unusual babais on the phone, that when you do something, can you them do this? They can decide to share their will, that give this to Lagbaja, give this to Kimin Khan. They will be doing something, they'll be passing messages across that okay, they want to do something, that something is about to happen to them. So one can as in take that from how you interact with them. Then there's some others that can actually write notes. On the other, there's some others, just some harmful objects around them. They could be purchasing it. You can see that a person that doesn't really use all these suicide and all these rat poison and all that. There's no rat in the house. The person is buying rat poison. So you just be wondering what does the person want to use it for? So all those things can just pinpoint. Then we also usually say that if one is struck with a tragedy, or if one is afflicted with maybe problems, that's when we always try to be around that person, so that we always want to be around that person. We don't want that person to be alone, so that in case that person has been initially prone to having depression before that tragedy struck, the person will now not finally go and do it. So those are some tips that one can get to know, or can get to, like, say that one wants to prevent suicide. But for people that one don't know, like, all those that you are walking along the streets, you suddenly find somebody wants to jump over. So I think the best one can just do at that point in time, once one notices that one wants to do one, is just to prevent the person and try to see how one can hand over the person to, the security operatives, to link up with the family, to link up with the social services and all that. Okay.
Are you okay? Brother Akindele?
Yes, I'm fine.
Okay, Sister Khadija Tijani.
Assalamu alaikum warahmatullahi wabarakatuh. A big thank you to our doctor, Dr. Lawal. May Almighty Allah continue to preserve you in goodness and happiness. The first thing I want to say is about, at times when you check people's status on, let's say, WhatsApp, you can, from what they post at times, you can depict something is actually going wrong. One day I was checking through the status, and one of my friend's son's number came up. I checked what the boy wrote, and to me, it sounded like the boy is about to end it. I quickly alert both parents. In fact, I called them, they were praying, they couldn't pay my call and all that. But when they did, I told them to quickly go and look at his status. But they were unable to, because he has blocked them already. They cannot see his status. So I told them what I observed. I screenshot, I sent it to them. And they kept watching. And by the second day, something happened, and it was like the thing now turned to a full-blown psychiatric issue. They have to quickly take him to RO because he wanted to kill his elder brother, the same guy. But up till now, they are still battling with solving that problem. It's from one hospital to another, and a relapse here and there. And from what they were told, drug wasn't the causative factor for him. Allah Alam. So what I'm saying here is that at times when you look at people's status, and you can actually decode from what they are saying, that it's like this person is undergoing a serious thing, one can actually get into contact with people that are very close to that person and tell them your observation. The second question, okay, this is now the question. There are some people that you can actually identify that they are depressed. But when you want to go closer or you talk about it, they will build a very strong barrier, block around themselves. You will not be able to reach out to them. And then if they see that this is, in fact, everybody is a suspect, that you might want to talk about their problem. So there is a brick around them. How do we help them? In fact, at times, when they see that it's like you want to get closer, probably you can discuss the problem with them, they will just stay off from you. How do we help this kind of people? Thank you, ma'am.
Okay. That's because, in our country, we don't have that social services network that we can use to fish out these people and get them to the hospital. So the best people will be like the family, the next of kin, the caregiver, somebody that can impound, that I've noticed this in you, and I think you need an assessment for it. So I think it's those people that they'll be able to impound on them more. Sometimes for people that are not, so sometimes for us as care that work in the hospital, if you're not able to get the family, or we can't easily get the family because of one reason or the other, you can also use, especially for staff of the hospital, we can also use the bosses, their bosses at work, to impound on them to do this. Otherwise, we start threatening them somehow, such that they can seek help. We can use their bosses, we can use their spiritual leaders, as a form of to convince them to say that these are things that think they are wrong and they should, assess proper assessment for what is wrong with them. So bosses, spiritual leaders, family can also be used, I think.
In the absence of any question, I think, is there any other question before? Because there's no question in the chat box. Okay, well, Ajiboye Zakaria, please go ahead. Well, Ajiboye, your hand is up now. Please go ahead.
Assalamu alaikum warahmatullahi wabarakatuh. I want to know. Yeah, please, I want to know if there could be opportunity for home service for the caregivers, because you have some situations whereby you wouldn't know when the symptoms start, showing. You won't know what is happening, and there are some situations, especially with the elderly or people of middle age, where you won't be able to detect then. But if we have an opportunity to bring a caregiver into the house to have a chat, indirectly, maybe he or she will be able to advise the family on how to go about it. Because at that stage, it may be difficult for one to get the person to the hospital, because he will tell you that he's not sick now, nothing is wrong with him. But you would have noticed certain things in him or her. So are there usually opportunities for, for psychologists or caregivers to go to the house to ask indirect questions, or to ask questions that indirectly, so that you'll be able to advise the family or the person on what to do and how to go about what is happening? Assalamu alaikum.
Yes, there are opportunities for home service for mental health, mental health services generally. I know that Arrow usually does like a bus or ambulance to actually go and take people that are very aggressive from their homes. But I don't know how much of that they are doing now, how they are doing it now. But I know that there should be of such service from them sometimes. That's at least for government hospitals. But I know that for a lot of private hospitals too also have that service, that they go to their houses to encourage them to come to the hospital, or in cases where they cannot agree, especially if it has turned to something else. Maybe they are psychotic, such that they are aggressive and all that. So there's nothing that you say that they will reason with you. So at that point in time, you have to force them into treatment first, get them, then after some time, they've used some medications, then you can see that they can start reasoning with you, and then you don't tell them the reasons why, and then everything continues to go well from there.
Are we okay, brother?
Thank you very much. I'm okay. Thank you.
Brother Badmo Scholar, you have the platform. Badmo Scholar.
Jazakumullah khairan. Yes, I'm speaking. Assalamu alaikum. Yeah, Jazakumullah khairan for the wonderful lecture. So my question is how do someone solve anxiety issues and low self-esteem?
Okay. For low self-esteem, that one is just like I would say that one is just like, it's not like a disorder in itself per se. It's just that one notices that, and one is trying to get out of it and all that. So one can talk to talk to psychologists or psychiatrists, such that they can help you. There will be like a form of psychotherapy sessions to understand why that person is coming down or has that persistent low self-esteem. They'll find out the reasons why, and they would find a way to solve it with the person through talking therapies most of the time. For anxiety, if it depends on the level of anxiety. So one needs to get a proper assessment first. So if it is a sub-threshold anxiety symptoms and all that, things that can talk through, or where they would undergo some interventions for them to surmount these anxiety symptoms, yes, they can do that too. Or if they will need medications, they will also, give it to them too. But the first thing is getting a proper assessment from a psychiatrist.
But about us, are we okay?
Yeah, thank you very much, Mara. Yeah, thank you, sir.
Thank you. And before we go, before we do the closing prayer, let me read the brief again, so that apart from having notes, our facilitator today, who has just delivered the lecture along with the question and answer, is Dr. Lawal Rafiat Oluwatosin. She's a consultant psychiatrist who specialized in child and adolescent mental health at the Federal Medical Center, Abeokuta. She was educated in child psychiatrics at Obafemi Awolowo University, and later did a master's in public health and adolescent mental health at the University of Ibadan. She's a fellow of the National Postgraduate Medical College of Nigeria, and she's married with children. Thank you very much. Should we go ahead and call our Sheikh to give us the closing remark before we call Sheikh Adelakun to give us the closing prayer? Sheikh Adelakun, closing remark. Sheikh Adelakun. Sheikh Adelakun, can give us the closing prayer, please.
Alhamdulillah, wassalatu wassalamu ala ma la nabiyyi ba'da rasuluna Muhammadi wa ala alihi wa sahbihi ajma'in. Innal hamdalillahi subhanahu nahmaduhu wa nasta'inuhu wa nastaghfiruhu wa nasta'dihi wa natawakkal alayhi. Lahu alhamdu fil awla wal ula wal akhirah. We thank Allah subhanahu wa ta'ala, we glorify him, we adore him, we appreciate him, most especially for preserving us to this very day, the first day of Muharram of the year 1446. Even though we don't celebrate, but we thank Allah subhanahu wa ta'ala. A Muslim does not celebrate, does not enjoy us, except when it's the Eid that is being prescribed by Allah. But then we have to thank him for everything that's done for us. He has given us a new life, an opportunity for us to increase in good deeds, an opportunity for us to seek forgiveness from him for all our shortcomings towards him, and to correct our mistakes to our fellow human being. An opportunity to increase in knowledge of why we are created. That's what we are doing today. We thank Allah subhanahu wa ta'ala for the opportunity. And we thank Allah subhanahu wa ta'ala for our beautiful sister who has just talked to us. It's given us a very, very educative lecture on the mental well-being. May Allah subhanahu wa ta'ala continue to be with her, increase her knowledge, increase her wisdom, bless her home, bless her business, bless her career, and then make whatever he's doing here as a means of to an al-Jannah, an evidence for him on the day of his resurrection, and an evidence against her and a family. And all of us who have led to lecture 2, we thank Allah for our life. May Allah make it beneficial to each and every one of us, and to have good impact on us this world and hereafter. ربنا لا تزغ قلوبنا بعد إذ هديتنا وهب لنا من لدنك رحمة إنك أنت الوهاب. ربنا إننا سمعنا مناديا ينادي الإيمان أن آمنوا بربكم فآمنا ربنا فاغفر لنا ذنوبنا وكفر عنا سيئاتنا وتوفنا مع الأبرار ربنا وآتنا ما وعدتنا على رسلك ولا تخزينا يوم القيامة إنك لا تخلف الميعاد ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار ولا تدع لنا في مقامنا هذا ذنب إلا غفرته ولا هم إلا فرجته ولا دين إلا قضيته ولا مريض إلا شفيته ولا عدو إلا هزمته ولا كربت إلا نفسته ولا حاجة من حوائج الدنيا هي لك رضا بالسلام إلا قضيته وستر يا أرحم الراحمين اللهم ربنا صل وسلم وبارك على حبيبك ونبيك محمد وعلى آله وصحبه أجمعين برحمتك يا أرحم الراحمين سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك لك سبحان ربك كما يصفون والسلام على المرسلين والحمد لله رب العالمين السلام عليكم ورحمة الله وبركاته.
Assalamu alaikum warahmatullahi wabarakatuh. We share the lecture within the next 5 minutes after we must have closed. For those that are not on AMP members, you can pick my number on the chat and reach out to us to share the platform with you, to share the stats with you. Thank you very much for coming. It has been a rewarding experience. We are grateful. Please be reminded that our AGM is coming on the first week of August. May Allah spare our life and make it a reality. Thank you very much.
Baba Adam. Thank you for the coordination. Thanks for the coordination.
Assalamu alaikum warahmatullahi wabarakatuh. Ẹ kú iṣẹ́ o.
Wà ló láti London.
Ẹ̀yin náà wà ń bẹ̀ wọ́n.
Ẹ̀yin náà wà bẹ̀ wọ́n. Ẹ kú ti new prime minister yín o.
Alhamdulilayi rabbil alamin.
Aláàfin diaspora.
Láti bó síbò.
Aláàfin diaspora.
À ń jẹ́ ìdílé wa o. Aláàfin diaspora. Assalamu alaikum warahmatullahi wabarakatuh.